We know that our healthcare system was incredibly challenged, and in some places are still incredibly challenged because basic public health measures that could crush the curve or reduce the spread was late or inadequately implemented.
This is one pandemic where digital acceleration is front and center in terms of, what it could do.
One of the best decisions which were made was the lockdown, because, India is a huge country and not necessarily the most disciplined. And I think the lockdown really helped to at least curtail it.
The cloud is great. It solves a lot of real-world problems, but it's not just one cloud anymore. Public clouds, private clouds, edge clouds. The average business uses 5 different cloud providers. It's become chaotic and complex, with unpredictable costs, inconsistent security, multiple management tools, and different formats for workloads that span cloud platforms and providers. But it doesn't have to be that way. The Dell Technologies Cloud, powered by VMware, can be the one constant across your clouds. It brings consistent infrastructure and operations to your multi-cloud environment, so you can choose the right cloud for each application. A public cloud that lets you easily tap into services. A private cloud that's fully under your control. Or the edge with cloud as a service. With a true hybrid cloud experience, your business becomes more agile with simple workload migration and easy onboarding for new assets. Your teams get to market faster. With simplified operations and automated processes, you reduce risk and strengthen your security profile. And with Dell Technologies Cloud, you have flexible consumption options, reducing your total cost of ownership. Like it or not, the business world often requires many clouds. Now, that's easier than ever, with consistent infrastructure, operations, and services across all your clouds. You get the cloud without the chaos. The Dell Technologies Cloud.
Hello, everyone. Welcome to TiEcon 2020 Health Track. It's been our pleasure to put together this track, and we look forward to the interactions between the panelists and the audience in the upcoming sessions. Our first session is on healthcare in a post-COVID world, opportunities for change. We have some well-known industry leaders and influencers that are speaking on this session today, including Prat Vemana, Chief Digital Officer at Kaiser Permanente, Dr. Preetha Reddy, Chairwoman of Apollo Hospitals, Dean Michelle, Dean of Public Health at Harvard University, Neil Gomes, Senior Vice President at Common Spirit Health, and Daniel Grossman, Chief Medical Officer at Best Buy Health. The speaker bios are on our website, so please take a look, and Daniel will be moderating this session. Over to you, Daniel, for a lively and engaging discussion on opportunities for change in a post-COVID world. Thank you.
What does science look like? Is it only in a lab where men in white coats peer into microscopes? No, science is here, in this moment, in every question and every small step forward. It's here, in our own backyards. It never stops. It's never done. But every once in a while, it changes everything.
Thank you very much. What a privilege to be here today, and it's a pleasure to be speaking with Prat, Preetha, Michelle, and Neil. Each of our panelists is going to spend a few minutes talking a little bit about their background and their particular organization. And then we will have an interactive discussion, take questions from the audience as well, and we'll direct those appropriately to folks. So if you have questions, please feel free to enter them into the chat, and we'll curate those to the appropriate panelist. I would love to kick this off with Prat. Prat, do you want to tell us a little bit? And then we'll go to Preetha, Michelle, and Neil. Prat?
Yeah, hi. For pleasure to be in such a great company, and really appreciate TiEcon doing such an amazing event across the board and creating the awareness in the healthcare space. So my background, I'm a Chief Digital Officer for Kaiser Permanente. It's an integrated care delivery organization that has both payer provider as well as integrated labs and pharmacy. My background, I came from retail industry prior to this for 10 years, leading digital in both Staples and Home Depot. Home Depot is the biggest, largest home improvement retailer, now in healthcare. It's a pleasure to be here.
Thank you, Prat. Preetha?
Thank you. It's a pleasure to be here, and namaste and good morning to all of you. I'm Preetha, Vice Chair of the Apollo Hospitals Group. We're a 37-year-old healthcare company. Started off as a hospital in Chennai, but now we're Asia's foremost an integrated healthcare system with more than 150 million individuals treated from around 100 countries. But the exciting thing is now, besides being just hospitals, clinics, we're the largest chain of retail pharmacies and have moved and embraced the digital ecosystem as quickly as we can, simply because, you know, there was a crisis in the country, and alongside the government, we're doing a lot in the digital space, and it'll be exciting to share those thoughts and learn from everybody else.
Thank you, Preetha. Dean Williams, Michelle.
Yes, thank you. Good morning, good afternoon, everyone. It's a pleasure to be a part of this conversation. I'm Michelle Williams. I'm an epidemiologist by training. I'm also the Dean of the Harvard T.H. Chan School of Public Health. And I'm delighted to be a part of this conversation because a lot of what is really fundamental to our thinking about a post-COVID world involves appreciating that much of the drivers of health and wellness exist in the spaces where people live, learn, work, and play, and that our integration fully and thoughtfully of population health and wellness measures, as well as healthcare delivery, that meets the access and the needs for all, is what's needed to help ensure that we have a population that's thriving and that's healthy and is equitably accessing quality care.
Thank you very much. Neil.
Well, thank you, Daniel, and thank you everyone from TiE for having us at this great event. I'm happy to be here. I currently am the System Senior Vice President for Digital and Human Experiences at Common Spirit Health. For those of you that haven't heard about Common Spirit Health, it's a relatively new company formed through the merger of Dignity Health and CHI, Catholic Health Initiatives. We are currently in this merged form, probably the largest not-for-profit mission-based health system in the US, about 140 hospitals and in 22 states. My job is a very exciting one, to bring all of these new innovations in healthcare into practice, build new business models on the clinical side, as well as with operations, and use technologies and platforms to make this all possible and sustainable. In my past, I worked at Thomas Jefferson University and Jefferson Health as the Chief Digital Officer there and EVP for Tech Innovation and Consumer Experience, and helped build some new innovations in healthcare as well as education. And prior to that, participated in the digital education revolution, right? For many years at the University of South Florida, helping build USF Online, and before that at the Tata Group of Companies out of India.
Thank you, Neil. I am so excited to have this group of panelists together. And I'll give you a little bit of my background as well. I'm the Chief Medical Officer of Best Buy. We have a division called Best Buy Health, which is a couple of years old, where we're actively working in the healthcare space. It's made up of a few acquisitions. I'm a practicing emergency physician at Mayo Clinic as a part-time gig along the way because I love practicing medicine, and had the distinct pleasure of working internationally, helping set up health systems, working with large ambulance systems across India as part of both my academic training and then deep in global health at Medtronic, one of the major medical device companies. Best Buy has a goal of enriching lives through technology and is relatively new entrant into the healthcare space, because if you're going to enrich lives through technology, one of the foremost places that you need to do that is in healthcare. And so that is one of our goals as an organization.
Make a positive contribution to society while also getting returns on your investment. One place to look is in developing countries and emerging markets where millions of people need better ways to address healthcare needs. Every year, countless people face catastrophic health expenses that lead to financial ruin, impacting them as individuals and families, but also society at large. One approach to address this need is creating a pay-as-you-go health wallet that individuals, particularly the poor, can use to finance or save for medical expenses and health insurance. If someone can automatically set aside a small amount of money on a regular basis, they will be prepared when a need arises and avoid a potentially catastrophic setback. The good news is the technology already exists to do this. And because the vast majority of people in the developing world have mobile phones, the time is right to create new and better tools to support their needs. In sub-Saharan Africa, mobile money accounts went from 200,000 in 2006 to over 277 million in 2016. One effort in Kenya has shown the health wallet model works. Mtiba users have demonstrated that it's possible to save, send, receive and pay for medical care all by mobile phone. We believe combining catalytic funding and first loss capital with private equity can get the job done and effect significant positive change.
As we kick off this panel, we'll take questions as well, but I'd actually like to start, it's not every day that you have a foremost epidemiologist and global health expert. And, there are all kinds of rumors and untruths and uncertainties out there, and we're dealing with COVID. We still don't know a lot about it. Dr. Williams, Dean Williams, will you just take a second, set the record straight? Where are we? What is COVID? What is the impact you're seeing? And just let's baseline.
Wow, that's, thank you, Daniel. That's a big question. And I'll tell you, let me just give a quick thumbnail. COVID-19 is a novel viral pathogen that we first caught wind of as a globe in late November, early December. And, we have been in the public health space, been ringing the alarm, sounding the alarm about it's not if a pandemic would come, it's when. And we and public health have been arguing for a very long time that we have to be prepared for this pandemic. Sadly, we were woefully unprepared. What I will say is, scientifically, we learned a lot very quickly about this new virus, very quickly. But we did very little in response to managing the spread of this virus. We now know that because public health measures that would require having a supply chain of personal protective equipment, having clear, comprehensive, coherent data available to help us understand the transmission dynamics were not on board for us in the public health and healthcare space to get out front of this pandemic. We know that there are vulnerable populations on account of high prevalence of non-communicable disease conditions like diabetes and hypertension and obesity that impact vulnerable populations. We now know that our early messaging around the public health interventions for managing and breaking the chain of transmission was not necessarily available to those essential workers who could not earn a living and continue to work remotely, for example. And we know that our healthcare system was incredibly challenged, and in some places are still incredibly challenged, because basic public health measures that could crush the curve or reduce the spread was late or inadequately implemented. And lastly, what this pandemic has done is laid bare the underlying threats in our public health and primary care delivery system that we, going forward, have to think about designing and doing better to build a coherent, robust, and resilient system, including caring for caregivers who are on the front lines and who are already suffering a massive amount of burnout. And one last thing, because this is a technology conversation, we also learned that we can deploy technology to provide telehealth. And we have learned important lessons about how to do that effectively in time of a pandemic, but also how to use technology to bridge the gap between limited capacity for clinical expertise in places that are remote from access to that clinical expertise.
Thank you. That's a great segue, I think, that'll kick us off. So, you covered technology gaps, you covered essential workers, you covered disparities in health, equity and racial equity, which we can come back to, and a public health system that was woefully unprepared, as you described it, and traditional healthcare systems that have had to evolve. So Prat, let me ask you a question. As coming from Kaiser Permanente, what is the reaction? How did Kaiser react, and what change has resulted both culturally and digitally as a result of COVID?
Yeah, first of all, similar to Michelle, I think we cannot thank the frontline enough, actually. I mean, they've done such an amazing job in being there and supporting the patients. And especially as the surge came in, we cannot thank them enough. This is one pandemic where digital acceleration is front and center in terms of, what it could do. We went from, anywhere from, depending on the day, 8 to 15% ambulatory care delivered virtually to as high as 90%, care delivered virtually, within Kaiser system. On an average, we are running about like 40,000 video visits a day now, actually, right? So, there are two pieces to this that was kind of interesting. One is these options were available pre-COVID, this telehealth and virtual care. The patients did not prefer that, nor the physicians, actually, right? There is something about being there in person. So the adoption was very little, if you will, actually, right? So with COVID-19, what it did do is accelerate that very heavily on both sides. Not only patients adopted to, seek care up to 90% of the ambulatory care delivered through virtual care, it's also the physicians, actually, how quickly we were able to actually bring them into the curve, actually, right? And expose them to various modalities. It's just not video visits all the way, even regular telephone visits, if you will, even the email visits, if you will, e-visits. How do you make sure that all types of modalities are available and the physicians are equipped, the care teams are equipped to actually manage that and work through that? And also some of the, as you can imagine, the logistics of it, right? How do you prepare and train and coach for delivery of care through virtual means? What does that look like? And, they're used to certain way of delivering care in certain ways. How do you shift to that? And then you take a step back, that is at the time of the care. But then when you think about mental health, behavioral health, social health, what we needed to push on is not just the acute scenarios, the non-acute and other scenarios that we needed to scale up, our mental health had to move very quickly to 100% virtual, actually. And you can imagine not only one-on-one consults, but group consults as well, right? So it has pushed us to adopt in a good way. I think, this allows us to actually scale and deliver care on time, wherever, the patients are, at their own convenience. I think that is a bigger swing that we saw from a digital perspective.
So Prat, let me stick with you for a second. You've reacted in a time of crisis. The next question, of course, is what do you carry through? What are the changes that you've made that become part of the ingrained culture and ingrained operating model of Kaiser Permanente? What are the ones that revert? And then you came from retail. So I moved to retail. You went from retail and came to healthcare. What are you drawing on from your prior experiences that are essential to carrying Kaiser into the next step?
Great question. Retail and healthcare, the value chains are very different. If you think about the construct of the value chain, is very, very different. When you think about the incentives are very different, the motivations are different, right? So in a way, retail 15 years ago was forced into a digital transformation, omni-channel, multi-channel, there's like convenience got redefined very, very quickly. Seamless experience meant very, very different things. So retail was thrusted into this 15 years ago. And now you can see that, especially in the last 120 days, the amount of the number of retailers who filed bankruptcy are the people who did not have a digital strategy, nor they were able to embrace the omni-digital strategy that needed to be actually, right? On the contrary, the top organizations like Home Depot and Walmart who embraced digital are actually not only thriving, but actually they're beating every expectation that you can. So I was fortunate to bring that experience into healthcare. Within healthcare, the way I'm thinking about this, Dr. Grossman, is that first wave of digital in healthcare was digitization of records, health records, medical records. I think, there was that wave that went in. The second wave is interoperability and digitizing the processes. If you went to the physician, if you call in to get an appointment, they asked you 10 questions, they digitize that same 10 questions, put it online. And, now you fill out that form and then you get an appointment, if you will, actually, right? So the second wave was digitization of the existing processes as is, plus, the interoperability. I go to a physician, I go to a pharmacy, I don't need to carry a paper anymore, it automatically transmits. The next wave of digital is going to be driven by this idea of what convenience means. Anytime care, anywhere care, if you will. What does that pivot look like? How do we embrace and adapt the tools and technologies to be able to provide that convenience? The second thing is going to be personalization. I think about, if I'm logging into a health system, you already know a lot about me, actually. So what could you make it easier for me to understand and help me get to the right care at the fastest possible way? Personalization is going to be a big wave. And also this idea of seamless experience, not just at the time of care, but my overall health and wellness. How do you make sure that digital can play a bigger role? I think there's huge opportunities there.
I was new to retail, as I said. I've been at Best Buy 10 months and came from med tech and insurance and practicing physician. So I was on the front row. I didn't expect to help a large retailer manage an unexpected pandemic. Totally crazy. But watching a retailer pivot its business model literally overnight, I mean, the lessons that you can take from retail and apply to healthcare are fascinating. We adjusted some of our clinical protocols, right? I can see a patient from home. I can see a patient outside of the room so that we don't expose more people to COVID. But watching a retailer just transform has been this formidable experience for me. And so I need to figure out how to apply that to back to healthcare as well. And Neil, you're working on a lot of the same things. Your experience as a customer-oriented person coming from Thomas Jefferson with your history of digitization, even in education, What are you looking for, Neil, as you think about Common Spirit's path forward, and who do you want to learn from? You're customer obsessed. What does that mean for you?
Great. Thank you for that question. Now, yes, and I've enjoyed listening to what Michelle and Pat also were saying, and agree to a lot of that. You know, there's a lot of transformation happening, but I still think there's lots to be learned from other industries. You know, and we're on this panel with so many people from different industries, you know, some kind of evolution from there. But I think there are things that we have to learn, and then things we have to apply, and then things we have to kind of evolve into, you know, in our industries, as well as look at other industries, but also appreciate the differences in healthcare. Right? It isn't exactly the same as most other industries. So initially, what I'd say is we have to try and learn from almost every possible industry, because both healthcare and the previous industry I was in, education, aren't exactly the early adopters in business, right? We kind of take the safe approach to things, and with good reason many times, you know, because we're dealing with lives here, not just selling things or something like that. But so it's very important, and we have a very strong trust relationship with our patients, so we have to ensure that that is well taken care of. I think we have to take the best principles and technologies out of each of these varied industries and then apply them to this unique healthcare industry. So some examples, you know, that we try to take from other industries. Unified digital experiences, you know, such as those that we see in the airline industry, for example, right? You usually don't have more than one digital experience with such organizations. It's unified under a single application or solution that you use. Ambient digital experiences, and creating those, like companies like Tesla, for example, that do that pretty well. You know, that tie the digital with the physical very well and knit them together, you know, exceptionally well. Then, you know, if you look at companies like Domino's, yes, even Domino's, right? And you look at their digital delivery systems and the way they've revolutionized themselves, you know, and disrupted themselves and created these great solutions in delivery, not just in pizza making and status tracking and those types of things. How about we apply them to healthcare and inform people more about where they are in a particular situation in their lives, right? Not just episodic, but even just focused on their health broadly. And then closed loop experiences, you know, like Amazon or Apple create, which they do really, really well. They do not leave us hanging, right, at any point in time. They always try to remind us also if we've even forgotten something that we then appreciate. And then I think personalized experiences, Prat spoke about some of this, right? We don't yet do that very well. And there are lessons to be learned from companies like maybe even Netflix, right? That know how to deliver these machine learning based personalized experiences to you so that you can engage with them in a more meaningful way. But as I said before, you know, healthcare is a very unique industry, and we have to take these learnings and then apply them in very different ways to us. But there's a lot to be learned, that's for sure.
So Neil, let me follow up. You mentioned airlines, Tesla, Netflix, Domino's, Apple, probably some more. I'm a wheelchair user. I'm a patient, right? I spent 4.5 months in the hospital. I get medical care from a variety of places, not closed loop, right? I go to different health systems if I need different things. Yeah. What is an ambient environment, and what does that mean for me? Can you translate that into like me as a patient and how that changes how I receive care? Sure.
Well, firstly, you described healthcare for a lot of people, right? I mean, it is fragmented. It is obtained from various different places. It's not necessarily always the one place, which is why I say that this is a very different industry from other industries too, right? And yes, you have choice in other industries, but here it is different levels of choice. It is different types of care, a single person may be accessing healthcare in various different types of ways. And And I think we need to take some responsibility for ensuring that that is one unique, well-knitted experience. And we're starting to do that, with interoperability, for data sharing, with unified experiences around even physical services like urgent care, or some that you described too, if it's rehabilitation, if it's physical therapy, these types of things. So there are some good standards around that, and organizations are starting to learn from each other and bright spots in the industry to try and deliver the same type of service. The one thing that isn't there in healthcare, and which is a little bit of a peeve of my own, is we don't really make or exercise our choices as consumers sometimes in healthcare as much as we do in other industries. So for example, if in the airline industry, we were really upset with service we received with, let's say, one airline, we'll pick a different airline many times, right? And we'll say, we're not flying with that one because I had a bad experience at so-and-so time. In healthcare, the value is not just a seat on an airline somewhere, or that momentary experience, right? It is your life. It is the life of someone you care about. It's some anxiety that you might have that is being relieved, that is really disturbing your life, right? So the value is very, very high. And then a lot of healthcare is also localized in many ways, right? So it's convenience and all of these different types of things. So you don't have a choice. It's sometimes connected to your insurance company. So I feel like we're a little bit soft in that way in healthcare, that we don't experience that kind of urgency from the consumer or that kind of pressure. But I think if we do that, and the system that does that, is going to redefine healthcare in many ways, and we have to. So we can't just think that healthcare ends, or our business ends when the person walks out of our hospital or a clinic. We have to really, really create this digital layer around them that connects them to us, assures not just their health care delivery, but also their overall health, which Michelle talked about earlier too, and Prat.
Yeah, I think we're going to get a ton of questions about what you just described. I mean, it's this vision of what healthcare should be, and we're not there yet. You and Prat and students coming out of the Chan School are going to reshape healthcare. Preetha, I'm curious for you, as you've sort of seen the world deal with COVID, and then it came to India. I'm gonna use the word advantage in a way that probably isn't really fair, but what was the advantage of having many other places be affected by COVID before it hit India? And how did Apollo, how did your healthcare system as a whole react to that?
So I think, when we started hearing about it, we really didn't think it would come in this magnitude across the world. And I live halfway across the world from all of you, and we kept watching and seeing. One of the best decisions which were made was the lockdown, because, India is a huge country and not necessarily the most disciplined. And I think the lockdown really helped to at least curtail it. Today, we're the largest in the world in terms of daily reporting of numbers, but it could have been much earlier and much worse. So I think the lockdown was only because we were probably, a little later, and the decision was great. As a private sector institution, what we did was we knew we couldn't do things by ourselves. So the collaboration helped. So multiple stakeholders, including the government, the private sector, everyone coming together, opening out facilities as soon as they can. And today, I think the private sector really handles much more in terms of actual COVID numbers than the government does, not because the public sector does not want to, but simply because the need is so much. So I think the collaboration has been fantastic. We have learned from lots of epidemiology data, standards of care, clinical protocols, which then we gleaned from all the other countries. And, we had to Indianize it a bit, because the comorbidities in India and the NCDs are so much more sometimes. And we also found that, our death rate is much less than many of the developed countries. And that is probably because, and Michelle, the epidemiologist, is here, and I know she'll have an answer to that. But Indians seem to be exposed much more, so I guess the immunity levels are much higher. I'm not so sure. And we do have a large young population. So when you look at the numbers and you look at the fatalities, I think the fatality number is much less. But the learning was to really, collaborate. And one of the most exciting collaborations was with the Global Association of Physicians of Indian Origin, which is the GAPIO. And they really came together and, they man some of the best centers globally. And there's another organization called API. So I think these came together and said, listen, this is the way. Can you look at these protocols? Can you quickly scale it up? The other thing Apollo did was what we call Kavach. Kavach means a shield. So under the program of Apollo Kavach, we did Apollo 24/7, which gives teleconsults, which had the first risk analysis for COVID, which later on the government picked up and did their Arogya Setu. But we were the first ones to do it, and over 2 million have actually used it. So I think that happened. And we had quarantine facilities, which were again collaborations. And now we run about 5,000 beds for quarantine across the country. So I think there were multiple interventions under one umbrella, which we called Kavach. And we continue to do it because, we don't know when that vaccine is going to come. And when it comes, I think the vaccine distribution and execution channels, again, Apollo as a private sector organization is gearing up to do. And we'll be working with the governments also to implement it as fast as we can.
So let me ask you a follow-up question. You described scale of vaccine distribution. You described adopting protocols that were already implemented across the world, having API and another organization sort of shift them for the Indian context of care delivery. What should we, the U.S. healthcare system, learn from you about what you have done? How do we take your lessons, your innovations, and actually apply them to our context?
I think speed of delivery has been humongous in India. Cutting on costs and just going direct to the consumer without going through multiple levels has really proven a success. And in a way, the healthcare system here cannot really, cannot afford to deliver the kind of care which you have in your country. Insurance penetration, while it's there, still does not pay the kind of bills which happens there. So I think we've learned to innovate. There's been an extraordinary explosion of innovation, just small interventions, small time apps. How can people access care quickly? How can they quarantine themselves at home so that, they get well soon? So there have been multiple interventions, which I think countries like you can learn from. And also, I think India has realized that we need to learn to manufacture. And one of our biggest successes was how a car company quickly turned around and started manufacturing low-cost ventilators. We were exporting PPEs at a cost. And now India is manufacturing the same PPE, same level at 20% of the cost, and now, seeing how they can export it. So I think in the manufacturing sector, we've done extremely well. Our digitization has leapfrogged, just like we did with the telephone technology, that, we really went from level 1 to level 4 and then to level 5. The same thing is happening in healthcare digitization, because the government has, quickly announced on our Independence Day, the National Health Digital Mission, which will scale up to a level where, it will penetrate more than 80% of our population. And I think just the speed of scaling up execution has been phenomenal.
Thank you. I think that's super helpful. I'm gonna take a couple of the things you talked about for digitization. We heard about personalization of care. We heard about digitalization. We heard about the lessons from Tesla, Netflix, Domino's, and changing care to make it more convenient. Dean Williams, when we do this, when we take these lessons that the leading health systems around the world are talking about, who are we leaving out? Who loses when we advance digitization and personalization, all these other things?
Yeah, thank you for that question. And I want to say it's really brilliant to see the amount of innovation that India has brought forth in the public health space. Before the shutdown, my colleagues and I at the India Research Center would engage with care delivery organizations like Apollo Health and the government organizations in these brilliant public-private partnerships that were really innovating around bringing primary health care, health and wellness to 400 million people in India who are currently outside of the formal healthcare system. So India was already beginning with public-private partnerships that were smart and really willing to experiment, innovate, test, and learn how to spread healthcare and wellness, the apparatus, to a large population that is currently outside. So I want to say that that kind of work helped position India to address, to respond to this crisis that Preetha so nicely summarized. To answer your question, Daniel, I think the key issue in public health is always to ask about who are we leaving out when innovation is coming forward. And in this space, I think we have to think, especially in the context of digital health, we have to think about those populations where bandwidth is disproportionately distributed. This is a very large problem in the United States and in other parts of the world, not only in the healthcare space, but also in the education space, as Neil can attest to. And so we have to think about when new technology is brought forward to help address healthcare needs and wellness needs, where are the pressure points? Where are the bottlenecks that will likely result in an extenuation of health disparities, not a reduction or elimination of health disparities? I think there's another question that is overlaid onto your question, Daniel, and is how do we retain the benefits and the wonderful fruits of the labor that we are now discovering from a rapid adoption of digital health in our space because of COVID? We have to be sure that the payment incentives remain in place so that we can sustain the embracing, the adoption of the digital health platform that is now being increasingly appreciated and utilized by patients and care providers. So we're going to need policy to help make sure that the payment incentives are there for continuing and possibly even expanding the digitization of healthcare services. But also we've got to think about populations where broadband is a big problem.
So I know we probably have lobbyists and other corporate folks listening in. So when you get your lobbyists going against ensuring that the pay continues and pays at parity, I think that's really important. And we've heard a lot about that in Washington as well. So we have a couple minutes left. We've gotten a couple questions about wearables and digitization. Let me kick this to both Prat and Neil in a minute, 30 seconds. What are you seeing? But more importantly, how are you going to adopt and implement wearables and digital solutions and not accentuate the digital divide that Dean Williams just described? How are you going to solve that problem while still adopting wearables and digital technologies? You have to answer both questions though.
All right, I'll do this. I think in terms of the digital divide, and we've done some research on this, in my past that Jefferson as well as other institutions have been at, a lot of even homeless people actually have smartphones because it's their way to sometimes get out of the situation they're in right now. But access to free Wi-Fi and other such services might be limited. But even in clinics where we've worked in the past, where we're serving even at no cost healthcare services, we found that most people do have smartphones. So it actually might be a way to get to people more efficiently than other means, like direct reaching out or having them come into a clinic. So I see it as a positive and a way to actually get to more people. From the wearable side, I would say right now what we have is early stage wearable development, where we're not really providing insights, we're just providing data. So we ingest that data through APIs we've built into our EMRs and all of that, and interfaces we build into the EMR. But ultimately, the clinician needs to get insights and complex insights, right? I mean, insights that are based on multiple different types of triggers. So that's I think the thing that we really need to build, and we need to push it to the last mile for the physician. That then when they're working on with the patient, they can see that contextually. They can see those insights contextually. They serve as a flag to them, rather than have interpretation be left up to them also. So we built some of those systems, both when I worked at Jepson as well as at ComSprit. We have several systems like those that are in place. I think that's the real future. And then at some point, we'll move probably from wearables to embeddables also, and that'll become even more important.
And we're shout out to Best Buy as the last mile provider for a lot of these things, helping the home actually become the site of care, which is what I think will help solve some of the digital divide issues and actually make the data you collect relevant because it's in a context that's outside of a traditional care setting. Prat, what are you seeing, and how are you going to take the innovations that you're using and simultaneously solve digital divide issues?
Yeah,
you're on mute, so.
So I'll quickly wrap up. The purpose-driven wearable usage is actually very impactful. So we were able to do a cardiac rehab study with wearables where we were able to provide the wearables and get the data back. Not only 2x compliance in terms of the rehab goals, but also we saw that we were able to directly impact the quality of the quality and the outcome of that study. So I think if it's built with purpose and it's clear on how we're going to use it and how it's applied, I think there is a clear impact. In the topic of inequality, I think it existed way too long. I think we have to confront it head on, but there are, in this crisis, it put a bigger light on it. And, being a mission-oriented organization like Kaiser Permanente, we were able to outreach, not through digital, as in like what you see in the apps or broadbands, but through offline modeling, ability to see who we need to intervene through social systems. How do we bring them into the right type of care? Otherwise they may be lapsing out of what they should be actually getting. So our ability to actually use data and digital more powerfully, not just through direct online means, but offline means, has a very big role to play in the inequality as well.
So listen, I've learned a ton. Thank you all for your wonderful insights. I think I can take this back to both my work and my clinical practice and how I think about being a patient. So I really appreciate this, your authenticity and openness to what we need to learn, where we need to go is excellent. Thank you very much, Dipti.
Thank you. Thank you, Daniel, for leading this very enlightening and very informative discussion with the leaders and executives from these prominent healthcare systems.